Welcome to the third and final installment of our lecture for hematology. Today we're going to talk about white blood cells, and then we're also going to look at hemostasis, which is blood clotting, and a couple of disorders, and we will be done with this particular chapter. So let's jump right in here and get started. White blood cells, when we think about these white blood cells, we know now that they're not all created equal. There are many different types of white blood cells, and when we think about these different types of white blood cells, it's going to be very important that you know for each particular white blood cell exactly what its function is. The reason this is so important is that then when we get a complete blood count and we look at the total number of white blood cells and then break that down by percentages of the individual ones that make up the total, we know that if they start to increase above what's considered normal, that can be very diagnostic. It can help us to understand what's going on in that patient. If you have, for example, if you have a patient with an infectious process happening, fevers are really high, they are exhibiting signs that there's some toxicity in the body going on, then just by getting a complete blood count and looking at the percentages of neutrophils versus lymphocytes versus monocytes, etc., it can actually give us answers within minutes of what we might be fighting. So if it is bacterial, then we want to give antimicrobials, antibiotics. If it is viral, then we know we need to deal with antiviral agents to help this patient. If it's allergy related, these eosinophil counts will go up. So it's really important that you know basically what these white blood cells do specifically as far as their functions go, and some basic ideas about what normal ranges are. Adult normal ranges for white blood cells are different than for pediatrics, but most textbooks give you what adult normal ranges are, and I'll give you the basic difference for that in just a second. So we think about white blood cells called leukocytes as being incredibly protective, and they really do protect us. And even though we understand that some of them are called granulocytes because they have obvious granules when we look at them with the right stain in hematology, all of them actually have these vesicles called lysosomes, which we know are from our cytology study. These are the enzymes that can digest and can help to break down old, worn out particles and even foreign particles as well. So looking at these, neutrophils fight against bacteria. An adult has roughly 75%, around that amount, about 75% of their total white count number should be neutrophils. So if you counted 100 white blood cells, 65% of the 100 would be neutrophils. Eosinophils, you'll see 2 to 4 for every 100 cells that you look at under a microscope on a blood film. So 2 to 4%, so roughly 3%. Basophils, less than 1%. So really rare to see a basophil, but they're still important because they do have granules that contain histamines and also heparin, but you really rarely see them. The only time that I've seen increased whites of basophils up to like 4 and 5 and 6% has been people who have cancer. Your textbook will talk about also some viruses being able to do this, like chickenpox virus, varicella zoster is the virus that causes chickenpox. And even some metabolic disorders like diabetes can sometimes cause this number to go up. We also have lymphocytes, which are the second predominating, so about 30% of the circulating white cells are going to be lymphocytes. These protect against viruses and also cancer cells that are forming, so we understand that lymphocytes protect against that. The major difference between adults' normal ranges and pediatrics is that the normal range number for the lymphocytes and the neutrophils are switched in pediatric population. So pediatric population is going to have 30+% neutrophils where they have a higher percent of lymphocytes. And maybe that kind of makes sense to you because in a pediatric population, this is when you're getting exposed to so many normal things that are in our ecosystems, but certainly so many microorganisms And it is these lymphocytes that are carrying out the function until someone's immune system reaches maturity, and then neutrophils start to predominate. So again, some rough numbers, excuse me. Monocytes, we said, become macrophages, big eaters, and you can have, roughly 5% circulating around, and around that number is considered to be normal. So please do have a rough idea about these normals. Neutrophils, 65%. I think I misspoke in the beginning. Eosinophils, about 3%. Basophils, less than 1%. You rarely see them on a blood film or see them reported because they're so few. Doesn't mean they're not important. They are, but you just don't need very many of them. Lymphocytes in adults, about 30%. And then monocytes, about 5%, around that. Okay, great. And again, this is telling you what I just told you about neutrophils, bacteria, eosinophils, allergies, and or parasites. Basophils, including having those histamine and heparin. So it's all right here. When you look at these under a right stain, and this is part of the complete blood count, the CBC, they look very different from each other. Neutrophils have very small granules, eosinophils, large histamine granules, basophils, large heparin and histamine granules. So lots of pictures that you can look at from your textbook on these. Most people are not going into diagnostic medicine, so you're not going to actually have to identify them. But if we were in a lab together, this is part of the lab that I always have students do, where they take their own blood and they do a blood differential where they make a blood film of their own blood, and I stain it for them, and then the next time they come in, the students do a blood differential on their own blood, as well as if they would like to figuring out their blood type if they don't know it already. Lymphocytes have a really large nucleus with very small amount of cytoplasm. You can see how very different a lymphocyte looks from these granulated cells that look so different from them, with a large round nucleus. Monocytes also have a really large nucleus, and the cell itself is really large, but the nucleus can sometimes be folded over. So just the differences in those cells. Now, where do they come from? They come from stem cells that are found in the red bone marrow. So the making of leukocytes, hormones will actually reach these stem cells that have a lot of potential, pluripotent stem cells, and whatever hormone gets there first, whatever signaling molecule gets there first, will dictate what this stem cell will differentiate into. Now, the earlier cells, the blast here, should never really be in the peripheral blood. Circulating in the peripheral blood should only be these mature cells. That's really important to understand. We don't want to see early cells, blast cells, in the peripheral blood. When we do, this is a diagnosis for leukemia. Leukemia is cancer of the white blood cell lines. Not all leukemias are created equal. Some are going to be of the lymphocytic line, some are going to be of the monocytic line, and some are going to be of the myelogenous line here. So once someone has if they do a CBC and they see the differential and they see blast, early white blood cells, they have to do a bone marrow exam and get some of the bone marrow, and then use special stains to figure out which type of leukemia it actually is. But depending on what you need, if you have a bacterial infection, you're going to send those cells that are being damaged and invaded are going to send signals, colony forming units here to this stem cell, and it becomes a neutrophil. If you're exposed to viruses and or cancer cells, lymphocytes. Parasites or allergens, eosinophils. Okay, so good. Now again, some terminology that would be really important to get from this is that if a total white count for an adult should be anywhere from 5 to 10,000 cells per microliter of blood. That is a normal range. If someone has lower than that, they're said to be leukopenic, or leukopenia is a term that's referring to a low white count. So leukopenic is the patient who has leukopenia. Anyway, low white count. You can imagine if they do have a low white count, they're at higher risk for infection. That's just logical to understand that. Some of the causes can be radiation, poisons, poor diets, and even infectious diseases. I know that sounds counterintuitive because if you have an infectious disease, it's usually when we see white cell counts go up. But actually there are a few infectious diseases that attack white blood cell lines, but also there's some infectious diseases that we know that it suppresses. They suppress the immune system. So these are some of the causes and effects of leukopenia. But can you have too many white cells, a really high one? Yes, and it's going to indicate that there's actually a bacterial infection. Maybe there's allergies. Maybe there's a viral infection. And we're going to know because we did a differential. We did that slide and we looked at the percentages of each of the different kinds of white blood cells so that we know what is going on. Leukemia, I told you, is cancer of this hemopoietic tissue that becomes white blood cells, the stem cell line, and it can either be myeloid or it can be lymphoid. So anyway, it can be one or the other, and it has to be diagnosed. A lot of people think leukemia is one thing. It's not. It's like breast cancer is not one thing. There are many different types of breast cancer, sort of an umbrella term, and then a definitive diagnosis would need to be made. So acute versus chronic. These terms mean, acute means that signs and symptoms come on rapidly and they're serious. Chronic means that they may come on much slower and it maybe even goes undetected. This is sometimes referred to as subclinical because it's not really presenting. It's come on so slowly, it's kind of undetected. Now, prognosis, whether you have acute leukemia versus chronic leukemia, the prognosis changes. And again, this is different from adult oncology than pediatric oncology. It's kind of the reverse in pediatric oncology. And I've probably mentioned before, but if I haven't, I'll say it again. Pediatric medicine is almost a completely different beast than internal medicine for adults. It's important to know that. So when we think about these lines not functioning anymore, when someone has leukemia and all of these early cells are being pushed out into the peripheral blood, they're just crowding the blood and they're not functioning. That's the problem. You might think to yourself, well, so what if the numbers are going up? They have such important functions. The numbers are going up and they're taking up space in the peripheral blood and they're not functioning. And that becomes a huge problem. So again, complete blood counts. It gives a hematocrit, hemoglobin, total red cells, total white cells, reticulocyte platelets. The blood differential smear is done with percentages of each, and there's quite a bit of information in a complete blood count. When you look at a normal field of view under a microscope, this would look normal, all these red blood cells, and occasionally you see nucleated cells and even the little platelets. And someone who has leukemia, this is what it would look like. This is a special stain, is why it looks different. The red cells look different in this than the right stain. But look at all of these early blast cells, and none of them are functioning. So you can see in a complete blood count where a blood differential is included, it takes minutes to do this after drawing blood on a patient, and this is an obvious diagnosis of leukemia. Now, hemostasis. This is not to be confused with homeostasis. Homeostasis is the balanced state of health. It's how the body keeps all parameters of everything: temperature, oxygen, CO2, blood calcium, glucose, everything within set point ranges. But hemostasis is the stopping of unwanted bleeding. Every day we're bleeding. We sneeze too hard, we break little capillaries, we stump our toes, we floss our teeth too hard, our gums too hard, our teeth. We do things. And so every day we're bleeding. But we have to stop potentially fatal leaks, if you will. And certainly even when you have an obvious injury, you want to make sure that the hemorrhagic event stops and that you don't bleed out. So how that happens is in 3 steps. And I'm going to want you to know the 3 steps. They're logical, they make sense, and I hope they will after we explain them. The first thing that happens is the vessel spasms. As the vessel spasms, whatever broke the vessel, the opening will close because the vessel spasmed. So that makes sense that with an injury to a vessel and an opening in a vessel, when it spasms, the openings get smaller. Platelets will then, that were circulating, will plug the opening. After the platelets plug it, a blood clot actually forms. This is called coagulation. And really, I know a lot of people think the platelets plugging is the clot, but really the blood clot coagulation is happening in this 3rd step. So we're going to take a look at each of these steps. Platelets do play a role in all 3 because platelets are playing a role as endocrine cells. It's hard to think about a platelet as being an endocrine producer cell when it's just a partial cell. Platelets are formed from these cells called megakaryocytes that end up, these are giant cells that end up exploding really, and partial pieces of these megakaryocytes, which I'm not going to ask you because you're not going to need to know about megakaryocytes, but these partial pieces, small fragments of that cell, will actually become hormone secretors and play a huge role in hemostasis. Now, the way that it does that is actually, again, by in each of the steps contributing to each of those steps, and we'll see how that actually happens. A normal platelet count is about 100 to 400,000 cells per microliter, so that's kind of a normal range, 100 to 400,000. And when we think about the functions, they secrete vasoconstrictors, causing the vessels to constrict, and that's what's actually there. By secreting that, they're playing a part in the 1st step, the vessel spasming. I'm having a tough time today, y'all. Put up with me, okay, please? Then, after the vessel spasms, the platelets will start to stick together and they'll form a little plug that seals the break. They do that by secreting these procoagulants, if you will, or clotting factors. And so we're going to take a look at the 3rd step, which is actually coagulation as well. So these are just some of the things that even help, look at this, they even help secrete growth factors that are going to help with the repair after the vessel is injured. And they are also going to help to bring monocytes to the site, which we said are our big dump trucks that become the macrophages that help to eat and destroy the bacteria. So platelets are amazing little pieces of cells that are playing a vital role in hemostasis. Again, as the vessel gets injured, it's going to spasm, platelets are going to plug, and then the coagulation step is actually going to happen. I want you to know that, let's see what I'm going to want you to know. Well, it tells you about the spasm here. Let's see if I'm forgetting anything to tell you about this. The platelets secrete serotonin, and y'all have heard of serotonin in the central nervous system having a function for just us functioning, but serotonin in your vessels actually play a huge role as a vasoconstrictor. So this is going to be what causes that vasoconstriction, and you're going to see how that happens. The endothelial cells of a capillary, these capillary endothelial cells secrete prostaglandins that are going prostacyclins that are going to repel the platelets. So they're going to be repelling the platelets as long as they're not injured. But when there's an injury that actually occurs, the endothelial are not secreting those prostacyclins, and now the platelets can plug. So that's the 2nd step. But let's take a look at the 3rd step, the very important coagulation step, where the clot actually forms, coagulation. So let's take a look at that step, because that is going to be a really important step. And we can do it from this slide. In your blood plasma, the liquid part of blood, you have circulating around blood clotting factors. These blood clotting factors have been labeled with Roman numerals. So like the first one, fibrinogen, factor 1, fibrinogen is a protein that will actually, if it's acted upon just the right way, it will become fibrin, which will become a fibrin polymer, which we call a blood clot. And if we've looked at a microscopic picture of a blood clot, you can see just how woven this is and how protective this would be for a vessel that has been actually injured. So what happens? What happens are two pathways, and they really are like dominoes. If you've ever played dominoes, or maybe you've seen someone play dominoes, each of the protein factors acts like a little domino in a cascade. And if one of them gets turned, hit, it's going to affect the next and the next and the next, just like a domino effect. And there are two pathways, the intrinsic and the extrinsic pathway. They both are occurring at the same time. They have different times that we actually know that they take, as far as how long they take, but they're both happening at the same time. And as these pathway domino effect cascades are occurring, it actually is going to eventually get you from fibrinogen to fibrin to a clot. You will notice that it not only takes blood clotting factors that have been labeled with Roman numerals, factor 8 right here, factor 7, y'all can see this, factor 10. Anyway, you can just look at this. These are just FYI. I want you to know blood clotting factors are by Roman numerals. They are, they all need to be present, because if you remove one from the domino cascade, it's going to hinder this from happening, getting from fibrinogen to fibrin clot. So taking any one away will interfere with blood clotting. You will also notice that calcium comes into the cascade at different points. See calcium here, 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 and here. So this is when we learned about blood calcium levels being so important to be maintained, because if they're not in homeostasis, blood calcium, it can interfere with blood clotting, and someone can bleed out if their calcium is not where it should be, if the calcium levels are too low. So we need all of the blood clotting factors. We need calcium. We need all of this to actually be in place for proper blood clotting. So when someone is lacking blood clotting factor, the most common one that's an inherited lack of a blood clotting factor is factor 8. That's the most common inherited lack of blood clotting factor. That's called hemophilia. Hemophilia A, it's referred to as, and that's the predominant inherited disorder of blood clotting factors. It used to be, before modern medicine, that people who were hemophiliacs or had hemophilia, they died young. They died from, skinning their knee, or, just what would be considered very minor for someone else. They could actually bleed out from. With modern medicine, we have transgenic bacteria that can actually make human blood clotting factor 8, and so it is inexpensive. It is readily available if you live in the right area of the world. Anyway, so it can be treated now so much more easily and less expensively than it could even like 40 years ago. So some other inherited factors that are lost, like factor 10, there's some other factors that we know can also be an inherited disorder. The factor 8 is the more common one that we actually see, though. Some of the factors are, even though on this cascade they may look like they're more prominent, some of them might not be even detected until someone is really stressed, like during childbirth with a loss of blood, or during a major injury like a car crash or whatever. and they're having trouble stopping bleeding, and they're wondering, like, why can't we stop this bleeding? And they find out that there was a lack of factor 10 or one of the other lesser factors. So hemostasis is proper blood clotting. It takes all of the factors to be present. The liver, the platelet. The liver produces thrombopoietin, which is going to be the hormone that causes platelets to form. So the liver, the platelets, all of these are contributors, and they're all necessary for a blood clot to form. As soon as the blood clot forms, though, it actually starts to lyse. It starts to be broken down. And this is important to understand because we do know for the clot to form, you're in a positive feedback loop. But it can't stay that way. We want the clot, but we don't want too big of a clot because too much of a clot would block the vessel. And then blood can't get to the tissues past that point. So it has to be just right, doesn't it? And so we understand that almost immediately the clot starts to retract. There's going to be lysis, splitting of, dissolving of the clot. And so we understand that this is actually going on in place too, because we don't want over blood, we don't want there to be too much blood clotting because that can be a problem as well. I had said that in normal situations to prevent we don't want inappropriate clotting. We don't typically have that because platelets can't stick to the inside of our vessels. They don't stick to the inside of a healthy vessel because the inside of a healthy vessel has prostacyclins that are repelling the platelets. But when the vessels get injured, that area doesn't have the prostacyclin, and that's why the platelets can stick. We know that thrombin and other factors are being diluted because blood is moving. It's very important that blood be moving and flowing. When blood starts to slow down, then it can clot. And this can be a very serious thing. So when someone is in shock, which means dangerously low blood pressure, that's what medical shock is, there's a real risk of abnormal clotting actually occurring. We have natural anticoagulants. We have heparin, I told you, from basophils and other cells, and this is going to keep you from having unwanted clotting. We have antithrombin from the liver, and that sort of is negating the effects of thrombin. So there are some disorders that actually we see, and I told you about hemophilia, and that most of them are hemophilia A, which is a lack of factor 8, but there are some others as well that we see. We know that hematomas are actual bruises where there's a mass of clotted blood in the tissue spaces, and it can take a while for hematomas to actually be reabsorbed, broken down and reabsorbed from the tissues. We know that we can have a thrombosis, which is a blood clot in an unbroken vessel. Should never have happened. A thrombus is the clot. So those clots can actually go to the lungs, and this certainly can be a life-threatening event. An embolism is something that's traveling. It's traveling through the blood, so it can block the vessels to the heart. It can get to the lungs. It can be to the cerebrum. So this can, an embolism is a life-threatening event, as we said. Infarction means tissue death due to lack of blood supply. So clots, whether they are in a stationary in a vessel, or whether they are moving, can lead to infarctions. You've heard of myocardial infarctions, which just means a heart attack. It means an infarction, a lack of blood supply to the heart muscle. Looking at these numbers, this sounds horrific, these numbers, and they kind of are horrific, actually, and not that uncommon, especially, in a person who's aging and cardiovascular systems are compromised. So preventing clots, vitamin K is required for the formation of clotting factors. So, you can look at some of these meds. Aspirin suppresses that. Some of these are actually called blood thinners, which can sound like a misnomer. They don't really thin out your blood. They don't really do that, but they act on those clotting intrinsic and extrinsic pathways. That's how they're actually preventing the unwanted clotting. So leeches, medical leeches, actually are used, and so this has been used for a long time. So sometimes we actually want blood to be coming to a surface site, so you can use leeches to sort of, they put out the anticoagulants so that blood can actually be pulled to the tissues. If you ever have tissues that look like they're losing blood supply for whatever reason, they can use those. We now actually have, instead of actual leeches, which are still used, we have mechanical leeches as well that have been patented and sometimes are used. Dissolving a clot, streptokinase is an enzyme that is from Streptococcus bacteria that we use to dissolve the clots. This has to be used in a very early period of the clot formation, or it doesn't do any good. So, and it also can be dangerous to use. So this is only done in in emergency sort of situations, but with physicians that are able to watch what is going on. TPA works faster as well. TPA, tissue plasminogen activator, so this actually can be used as well. And anyway, those are the two major ones that are used in developed countries are going to be the TPA and the streptokinase to actually break up a clot. So there is something else that I think is not on here, that, unless I just missed it, but I don't think it's on here, and I've got to tell you about it. It's called DIC. DIC, and maybe I went through it and missed it on the slide. It's one of those days, but let me go ahead and tell you about DIC. DIC stands for Disseminated Intravascular Coagulation. Disseminated intravascular coagulation. When that is actually happening, it should have been like right here. But anyway, when that is happening, disseminated means throughout. It's not just in one little local area, like a pulmonary embolism. Throughout, disseminated throughout the body, you're throwing blood clots. When this happens, it happens suddenly in patients, and we're talking about minutes that make a huge difference. Because what is going to be happening, it is really kind of counterintuitive to think about, but when you are making all of those tiny little clots, you're pulling out clotting factors into the clot, so actually the person is bleeding out. So they're really typically hemorrhaging because they've thrown so many tiny little clots throughout. So what you're going to see is a person, usually in their extremities first, they're becoming cyanotic. The tissues are starving, turning blue or purple or darkening, because the tissues are starving for oxygen. And again, minutes make a difference in disseminated intravascular coagulation, where inside the vessels, blood clotting is happening, just hundreds and millions of little clots are forming, cutting off blood supply to the extremities, and it's progressive. Because as it's happening, if you can't break the cycle, it is a life-threatening event always. If you can't break the cycle within the few minutes of time that it begins, then it's a fatal event. And even the people that I have seen as patients that survive DIC events, disseminated intravascular coagulation events, most of them have lost some sort of extremity. I have seen a patient who actually lost all extremities, legs and arms, survived the event, got it to stop, but lost those extremities. But it has a very high mortality rate when that happens. DIC can happen for a couple of different reasons. You'll see it sometimes post-infectious processes. So people can have a certain infection that will trigger this kind of event to happen. Some, it's rare, thank goodness, but some women, after they deliver, their blood volume changes so drastically. A woman in her last trimester, her blood volume will have increased by 30% to support the developing fetus. And then after delivery, the homeostasis is got to get back in balance and whatnot, but it can be thrown off. And sometimes after postpartum, after delivery, within a week or so after delivery, this can sometimes be a life-threatening event to a new mother. So there are a few things that can lead to DIC. It's never a good thing. It's a life-threatening event, and the clotting has to be stopped immediately. So again, the reason that it sounds kind of weird, but the reason it has to be stopped is because the blood clotting factors are being pulled to those little tiny blood clots, and it means that they're bleeding out of other areas, so their blood volume is dropping drastically, and they go into medical shock, and again, minutes make a difference. So DIC. That's the end of our hematology talk. I hope that you have found out a lot about blood, more than you maybe knew going into these talks, and I'll look forward to seeing you guys, or having you all in the next section, which is going to be about the heart.